Okay, welcome to Chapter 1, Phlebotomy, Past, Present, and the Healthcare Setting. We're going to be looking at a historical perspective of phlebotomy and where it comes from, the practices of phlebotomy in earlier dates. The practice of phlebotomy has been around for ages. We see it in Egypt in 1400 BC, where we have discovered tomb paintings that show leeches or leeching, the practice of leeching, being applied to patients for bloodletting. In 460 to 377 BC, health depended on a balance of four humors inside the body: blood, phlegm, black bile, and yellow bile. The balance of these determined if you were healthy or sick. And bloodletting was often used to remove excess humor of whatever type the doctor thought you had more of than the rest. If your body was off balance or one of these humors was off balance, it caused you to have illnesses. In the 17th and 18th centuries, phlebotomy became a major therapy. Lancets and fleams were used to cut veins and arteries, and cupping and leeching were more widely practiced. So we know that in history, bloodletting is something that was thought to cure diseases and illnesses, when in reality it really wasn't a safe practice. But they started doing it and seeing results to some degree. They used pretty crude tools, so this photo here is an example of lancets that were used to cut and drain blood vessels. Barber surgeons would perform bloodletting and leeching, which is using leeches to suck blood out of a patient. The barber poles we see today at barber shops, if you drive past a barber shop and you see the red and white spiral poles, those are from early times when barbers were also doctors and surgeons. They're indicative of that doctor-surgeon role. So they represent the blood of a patient. The red and white stripes represent the blood. And then this is a picture of a bleeding bowl. Bleeding bowls were used to collect blood from patients. There is a slot in the bowl for whatever extremity, most likely a wrist. So they would cut the wrist, the artery or the veins, and they would place the patient's extremity in the bowl and just let it bleed into the bowl. That's bloodletting. We still have some methods from then that we use today. Cupping and dry cupping is one that you see used for athletes and recovery, pulling blood to the surface, pulling blood into the tissues to help regenerate. This penetrates deep into tissues, mobilizing blood flow and causing the tissues to release harmful toxins that can then be removed from the body. And then leeching is also used sometimes. It's not widely used, but it can be used as an aid in microsurgery procedures, such as skin grafts and reattachment of severed limbs and digits. Leech saliva contains a local vasodilator, anesthetic, and anticoagulant. So it is helpful in the clotting and healing process. Goals and methods of phlebotomy today differ greatly from when phlebotomy was first practiced. Our goals today are to provide excellent patient care while obtaining blood specimens for diagnostic purposes and monitoring treatments, removing blood for transfusions at donor centers, and removing blood for therapeutic purposes. We do these things and we reach these goals using the methods of venipuncture, which is where we collect blood via a needle inserted into a vein. It's kind of our main method of collecting blood. Capillary puncture, blood collection via a lancet puncture of the skin, and these are going to be finger and heel pokes. And then arterial punctures, which is a blood collection via a needle inserted into an artery. This is not something that phlebotomists do much anymore unless they have special training. Most of the time now, it will be respiratory therapists that do these because it's specifically pulling blood gases, arterial blood gases that are used for monitoring respiratory therapy. So, to become a phlebotomist, you need a certificate at least, which is a document granted by an agency or school, that requires a completion of academic as well as hands-on training requirements, which is what we're doing here in class. You get a certificate, you complete the didactic material, which is your online course and the hourly requirement for the class, and then you also complete a skills requirement. And they're different everywhere, it varies, but there is a skills requirement for you to graduate. You do then have to attain a satisfactory score on a comprehensive exam. We have a final exam, and then you can go on to do a national exam if you'd like. And once you receive a passing score, you're then nationally certified. So you can be certified at the class level and certified at the national level. The class may be voluntary, so most of you signed up on your own to gain more skills for the workforce or for your resume. Some employers will send students or send their employees to the class as a student to gain skills for their job specifically. A license is an official document or permit granted by a state agency that is recognized by law. This requires specific education, experience, and passing an exam. So again, you can go on to take the national exam for the licensure, the phlebotomy licensure. Continuing education is designed to update the knowledge and skills for specific groups of healthcare professionals. Continuing education is something that you can get online. Participating in continuing education can help prevent costly errors and reduce the risk of lawsuits. The more you practice and the more you stay up to date with changes in curriculum, changes in policies, the less likely you are to come in to experience issues regarding policies and stuff like that when you are poking people. Moving on into professionalism in the healthcare setting, it's really important to be professional. Maintaining a professional appearance, having self-confidence, integrity, compassion, self-motivation, dependability, and behaving ethically are all very important. Self-confidence. A phlebotomist who displays self-confidence is able to trust his or her own judgment. Perception is reality to patients. So this means if you enter a room and you appear calm, confident, and like you can get the job done and you know what you're doing, you're not going to be questioned by the patient as to how long you've been doing it, or maybe you will be, but you can give confident answers. So, but if you appear timid or you appear shy or you make it seem like this is your first time, they're going to be suspicious and wary of that and ask you questions based on your experience. The more self-confident you appear, or he or she appears, the more professional you appear to the patient. So just keep that in mind. One of the main goals for this class and when we practice skills is to instill confidence in you as you go through learning and practicing the skills, and then have you leave this course feeling confident as you go into a job potentially. Integrity is a personal feeling of wholeness derived from honesty and consistency of character that can be seen in a person's actions, values, and beliefs. This just means do what's right regardless of the circumstances. There is a potential for you to be put into a situation where you're asked to do something. For example, there is a minimum and a maximum There's a minimum and a maximum amount of blood that can be drawn from a patient per day, per week, per month. There can be times where we're drawing so much blood from a patient, running lots of labs to try to figure things out, where you're taking the maximum amount and you do run into these caps on the blood you can take, but you might be asked to take more than we're allowed to take, which can be very dangerous and cause anemia in a patient and sometimes even death if you take too much. It's based on weight, so I'm talking more in the range of very small patients, infants, children, okay? So just be aware that there can be situations where you're asked to do more than we're allowed, okay? It becomes out of our scope at that point, so remember to do what's right, okay? You have people that will back you up. Protect yourself, protect your job, protect your integrity. Compassion is being sensitive to a person's needs and willing to offer reassurance in a caring and humane way. We always want to be compassionate to the patients that we experience, no matter what job we go into. But you need to think about when you're working, especially in a hospital. People come in and they're sick, they're lonely, they might not have anyone there with them, they're scared, okay? So they will want to talk to you about their lives and their families, and they'll want to talk to you about their problems and maybe say some pretty crazy things to you, and that is okay. All we need to do is show compassion to them, express to them that we are here to help, and help them feel like they're in a safe space. We want to make sure that they feel like they're in a safe space with us, okay? So be compassionate, be caring, be kind. This is more of a personal, professional subject. Self-motivation is taking initiative to follow through on tasks, consistently striving to improve or correct behavior, and taking advantage of every opportunity. Every employer likes to see someone who is self-motivated, who is motivated to take the initiative to do tasks. So an example of this would be to make sure that you are stocking equipment. If there's something that needs to be done, you're doing it, and everything is done before you take leisurely time for yourself, right? And of course, jobs are going to have breaks and stuff, but you don't just want to be sitting around doing nothing when there's things to be done. Employers really like to see, as you already may know, self-motivation and the initiative being taken to get things done. This goes straight into dependability. Are you a dependable employee? Someone who works hard and shows constant, reliable effort and perseverance. These people who are dependable, show up on time, complete tasks, take pride in their work, take the initiative to get tasks done, are valuable assets to a healthcare organization and are recognized far more than someone who kind of just skates by. Ethical behavior is important as well. Ethics are a system of moral principles and standards that govern conduct and the distinction between right and wrong. We all know what right and wrong is. It's up to us to make the choice between right and wrong and what we do and the actions we take. There are policies in place which are a code of ethics. Each employer has their own policies and code of ethics, which leads to uniformity and defines the expectations of the company you work for. Okay, so just make sure that you are aware of what the policies and the code of ethics are, and even if you might not agree, you're still following the code of ethics and making ethical choices and ethical behavior. Patients have rights. They do have a right to confidentiality, which is really important as we talk about HIPAA, okay, especially working in like the healthcare field. HIPAA is something you'll probably hear about a lot. All patient information is completely private and confidential because of HIPAA. It was enacted in 1996. It is the Health Insurance Portability and Accountability Act. This requires that all healthcare providers obtain a patient's consent in writing before disclosing medical information to any unauthorized person. This is transferring medical information of a patient to a new doctor. This is transferring medical information of a patient to family. It has to be signed off on a consent form by the patient, unless the patient is a minor, in which case the parent would be the consenter, or if the patient is incapacitated, in which case they wouldn't be able to sign or do anything on their own, so like a living will, things like that, if they have like a designated person that you would give medical information to. So on page 9, you'll see the protected health information that gives more detail on this. There are 2 documents that have been published to strengthen consumer confidence, so patient confidence and their right to be involved in their care. The first is the Patient Bill of Rights in Medicare and Medicaid, and the American Hospital Association's the Patient Care Partnership. These 2 things have greatly changed the way patients are involved in their health care, which means we are giving them the information, all of the information associated with their care, and they're able to be present in making a decision in their care. So that, for us, for example, would be coming into the room and saying, hello, my name is Samantha. I'm here to take a blood sample. Is that okay? The blood sample is for this, this, and this, and they have received the information. They say yes or no, but they give you the consent, the informed consent to do your job. It has been found that patients who are informed about their treatment and prognosis and who are considered part of the decision-making process are more satisfied with their care. So this is instead of providers like us or the doctor saying, this is what's happening and this is what we're going to do and you have no choice. We're saying, this is what's happening, this is what we're going to do, this is the outcome. Is that okay with you? Or we can do this instead. It gives them more control over their own care in situations where they're sick or scared, okay? The American Hospital Association's Patient Care Partnership is built with these sections of the pie. We help with billing claims. So we help patients with billing claims. They don't have to do things all on their own. We provide high quality hospital care. We provide a clean and safe environment. We allow the patient to be involved in their care. We protect the patient's privacy, and we offer help when they're leaving the hospital. All of these create an environment where the patient feels comfortable and better about receiving care from large organizations. Hospital facilities have different tiers. There is inpatient, which is a non-ambulatory service. The Key Resource and Center of the American Healthcare System offers specialized instrumentation and technology to assist in unusual or emergent diagnosis and treatment. Examples include acute care hospitals, nursing homes, and hospice. Outpatient is ambulatory services, which are medical care delivered on an outpatient basis. Patients requiring care after discharge from the hospital. Examples include freestanding medical care settings, hospital-owned clinics, outpatient departments, and urgent care facilities. And then homebound services, which are patient homes and long-term care facilities where providers go to the location to provide care. Hospital services and the characteristics of a hospital are as follows. To be classified as a hospital, there need to be permanent inpatient beds, 24-hour staffing service, therapeutic and diagnostic services, and an organized medical staff. So the hospital is organized into different sections. Each floor is a specialty, and each specialty has workers that are specifically trained for that specialty. So for example, ICU, the cardiac unit, emergency department, stuff like that, okay? Hospitals are typically organized into departments or medical specialties, which is where the specialty training comes for the employees. Healthcare financing is something that we don't deal with too much because there's typically a financial department. But we have a couple of different methods of payment, which include direct payment, where the patient pays the provider directly, indirect payment or a third-party payment, which is an insurance company, federal government managed care program, or self-insured company pays the provider. We also have diagnosis and billing codes, which we also don't get too much into as phlebotomists. The current procedural terminology codes are on table 1-5 if you want to look at those more. And then reimbursement programs include Medicare and Medicaid. So all of these are payment programs, and depending on each individual and their financial status, kind of determines where they're going to fall in this financing bracket. Communication is very, very important in phlebotomy and really in any healthcare setting or workplace in general. But the components of communication are verbal communication, which is through the spoken word, okay? You have conversations with people, you get information, you exchange information, and you communicate through the spoken word. Active listening, taking steps to ensure the listener is interpreting what the speaker is saying exactly as the speaker has intended. So when you're having a conversation, you're listening to the person you're speaking to, decoding or digesting what they have given you, what they have said, okay? You're decoding the message, and then you're responding. Then they're actively listening to you and your response. They're decoding your message and they're responding. That's how that works. And then nonverbal is body language, facial expressions, an eye roll, or your body language, turning away from someone, acting a certain way towards someone. You can generally tell how people feel towards you based off of how they act towards you, okay? The way they look at you, the way they present themselves to you. Nonverbal body language includes kinesics, which is facial expressions, gestures, eye contact, and proxemics, personal space. So body language is a good way to communicate with patients as well. So make sure that you're making your presence known. You're walking into a room and you're saying, knock, 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 hello. I'm here from the lab. My name is Samantha. Establish a rapport. How are you today? Okay, state your intentions. I'm here to take a blood sample. Is that okay? So make yourself known, establish your intentions, and establish a rapport with the patient so that you can move forward. This is an example of the communication loop. We have an encoded message from the sender. And all of these subjects are important when it comes to communication because they affect the way that we communicate. Culture, gender, emotion, language, physical issues, and age are all components in communication, and they affect the way that we communicate with people. I probably wouldn't speak to my husband the same way I speak to my grandmother, or even a little kid the same way I would speak to my grandmother or my mother, okay? Age and all of these different things, gender, they play a role in communication. And then when the receiver decodes the message, they give feedback, and it's a never-ending loop of communication. Communication stems into or goes into telephone etiquette. We want to make sure that we're keeping communication positive over the phone, and a lot of times, especially in healthcare or really any like over-the-phone kind of conversation that has to do with hospitals or maybe even like financial things, appointments, there can be things that are tricky, so like upset patients. So proper telephone etiquette and protocol is very important. It impacts the quality of patient care. I don't know if any of you have experienced a negative telephone call, but it really affects your mood, and also it gives you a general idea of the service that you're going to be receiving. So telephone etiquette is vital to efficient and effective services. Answer promptly. We want to try to get to the telephone before the third ring. So after 2 rings, state your name and your department. Hi, my name is Samantha with the lab. How can I help you? Or thank you for calling St. Luke's Laboratory or St. Al's Laboratory or wherever you work. Thank you for calling the laboratory. My name is Samantha. How can I help? Be as helpful as you can, and you're not going to be able to help with everything, right? If it's something that you don't know what to do, send them to the right person. Prioritize calls, transfer and put on hold properly. Make sure you don't forget people. If people are left on hold for too long, then they start to get antsy and agitated. Record patient information. That is important. So that would be name, date of birth. So first, last name, date of birth, maybe their patient number or medical record number, their appointment date, maybe their doctor. It kind of just depends on what they're calling for and the information you're providing. Know your laboratory policies, diffuse and de-escalate hostile situations, assist everyone to find the right answer. If you don't know the answer, you're more than welcome to place them on a brief hold and go find somebody or transfer them to someone who does know so that they can get the answer they're looking for. And also, kind of going back to this, one last thing, if there isn't anybody that knows the answer to the questions that someone is asking on the phone, you can absolutely take their information and call back later. If you need to research it or look into it or contact someone who might know to get the answer and then call them back and give them an answer, that's better than nothing at all. Okay, so just keep that in mind. Clinical laboratory services include 2 major areas of lab analysis, which are the clinical analysis area and anatomical and surgical pathology. So the clinical analysis area is where the blood goes that we collect, and anatomical and surgical pathology is where the physical, like tissue samples and like larger samples go. All laboratory testing is associated with these 2 areas. Similar tasks are grouped into departments. The goal is to perform each task accurately, efficiently, and cost effectively. So this just means that we're grouping similar tasks into the same department so that we can run multiple tests at once instead of one tube of blood at a time, right? So if we have, for example, multiple gray tubes that need to be tested, we can run those all at once or as many as fit into the machine rather than one tube at a time, because it does cost money to run the machine and to get results from these tests. So if we can run 10 or 6 instead of one at a time, then that just greatly reduces the costs for us. The types of laboratories are as follows. We have stat labs, which are established in some tertiary care facilities, typically located in or connected to emergency rooms. They are for procedures and tests needed immediately. Now, for example, St. Luke's and St. Al's have laboratories that are based in the hospital. They're connected by one door to the emergency department. They're very easy to access from the emergency department. And that's because a lot of labs that come from the emergency department are stat labs. People come in for emergencies. They need results quickly. Excuse me. And so stat labs are mostly located in larger hospitals. It's the main lab there. Reference labs are larger independent labs. They receive specimens from many facilities in city, state, or region. They provide routine and specialized analysis of blood tissue and urine and offer fast turnaround times and reduced cost due to high volumes. So blood comes in from all different hospitals, smaller clinics, urgent cares, okay? And these reference labs run the blood or the samples in a higher quantity. So they put out fast turnaround times and results at a reduced cost because of the high volume. The blood is transferred to reference labs via a courier who comes maybe every 30 minutes to 1 hour to pick up blood, and then they take whatever isn't super urgent or emergent to the reference lab. There are different laboratory departments, which we'll get into more as we talk about the order of draw and transporting blood to the laboratory. And this is just for like larger hospitals, okay? So when we're drawing multiple tubes, each tube goes to a different section of the lab based on what it's testing for. So we do have blood bank and immunohematology, which is blood for transfusion. So we're gonna have certain tubes go there, for example, a type and screen, because it's a blood bank, we're typing blood. Hematology is a blood and blood forming tissues department, and so whole blood samples will go to hematology. Coagulation is the ability of blood to form and dissolve clots, so the coagulation department will be a part of hematology or a sub-lab of hematology, but also a whole blood test. Chemistry is for lab tests. Serology and immunology are serum and autoimmune reaction, are where serum and autoimmune reaction tests go. That is a sub-lab of chemistry. Urinalysis is for urine tests, and microbiology is for microorganisms in body fluid and tissues. So microbiology is for example, where like a blood culture would go. We also have anatomical and surgical pathology, which is where the microscopic tissues or the tissue samples or the physical samples of the human body go. Histology is for microscopic structure of the tissues. Cytology is the structure of cells, and cytogenetics is the chromosomal deficiencies and genetic disease department. We'll go more in depth into this when we practice poking, and we'll practice which tests go to which lab. But our common chemistry tests include a basic metabolic panel, comprehensive metabolic panel, electrolyte panel, hepatic function panel, lipid panel, renal function panel. And again, we're on page 24, tables 1-7. Moving to table 1-8, hematology tests, hematocrit, hemoglobin, red blood cell count, white blood cell count, platelet counts, and differential white counts, which is just the specific amount of each white blood cell. There are 5 white blood cells in the body, so it just gives you the count of each specific type. Page 24, Table 1-8, these are our whole blood samples for hematology. Page 25, 1-9, these are our common coagulation tests. So remember our sublab of hematology, but still whole blood tests. Activated partial thromboplastin time, D-dimer, fibrin split products, fibrinogen, PT-INR, which is prothrombin time / international normalized ratio, and thrombin time. These are tests specifically for clotting, blood clotting, and clotting factors. It determines how the patient's blood clots in and outside of the body. Okay, so I know that this means nothing to you right now, but it will as we move forward in the course. Okay, so these are just examples of the most common tests. Serology and immunology tests. Anti-nuclear antibodies, or ANAs, cytomegalovirus, hepatitis C, immunoglobulins, Epstein-Barr virus, rapid plasma reagents, human immunodeficiency viruses, or HIV, hepatitis B, surface antigen, and rheumatoid factor. This is Table 1-10, page 26. UA tests, or urinalysis tests, are on Table 1-11, page 27. When we are taking a urine sample, the things we are looking for include color, clarity, blood, the bilirubin levels, glucose levels, ketones, proteins, and nitrite levels. So we're looking at the levels of all of the vitamins and minerals in the blood, as well as what the urine looks like. Color, clarity, are there particles floating in it or crystals, stuff like that. Common microbiology tests include blood cultures, fungus cultures, CLO tests, which is a breath test, gram stains, and acid-fast bacilles. Table 1-12, page 28. Blood bank and immunohematology tests include type and screens, type and cross-match, which are the same thing we'll talk about a little later. Type and RH, so the blood type and whether they have the RH factor or not. Antibody screen, and compatibility testing. Table 1-13, page 29. And then we're moving on into the type of personnel that's within each lab. So we have at the top a laboratory director or pathologist who manages the lab along with an administrator or the administrators of the hospital. Maybe a pathologist or a clinical lab scientist. A pathologist is a physician who specializes in diagnosing disease. Laboratory administrator or laboratory manager, usually a technologist with advanced degree and experience, oversees all operations involving physician and patient services, may supervise ancillary services, which include respiratory therapy and radiology, as well as phlebotomy. Okay, it can fall under that ancillary service category. Technical supervisors administer a lab section or subsection, report to a lab administrator, have additional education in one or more lab areas. Medical technologists or a medical laboratory scientist typically has a bachelor's degree plus study in a medical technologist program, performs all levels of testing in any area of the lab and report the results. So they can kind of move around to each section of the lab and they know how to do, like run the different machines and run different types of tests. They perform quality control and evaluate new procedures and maintain their own instruments. So they know how to clean and how to maintain the instruments, how to make sure the instruments are running correctly and program them as well. Medical laboratory technician typically has an associate's degree, performs routine testing, operates and maintains all equipment as well. A CLA or clinical laboratory assistant has phlebotomy experience, has skills in processing and basic lab testing, and is a generalist. So they assist the MLS or MLT in any area. So they are a phlebotomist, processing, or medical laboratory technologist hybrid. So they can perform phlebotomy as well as process samples and perform testing on the samples. Instead of just one or the other, they can do both. Phlebotomist, which is kind of where we fall into, right? We're phlebotomists. Collects blood for lab tests for diagnosis, care, for diagnosis and care of patients. Often serves in the role of laboratory assistant or specimen processor. So we can also process specimens, but we can't run tests on the samples. We can process them, take them to, so processing is just entering them into the lab, taking them to the designated area where they need to go or where they belong. Formal programs usually require a high school diploma or equivalent to enroll. Other lab personnel include computer programmers, so like our IT friends, laboratory information system managers, quality assurance managers, and point of care coordinators. All of these specialties and all of these are people who help the lab run smoothly, efficiently, and keep everything going. This is kind of a visual aid over the Department of Laboratory Medicine and Pathology. So the director of anatomical and surgical pathology would be in charge of histology, cytology, and surgical pathology. The supervisor of point of care would be in charge of outpatient service and nursing point of care testing. The supervisor of the blood bank or immunohematology would be in charge of transfusion medicine. So receiving the type-in screens, blood typing the blood, and making sure that the patients that need blood transfusions are receiving the correct blood type at the correct time. Things like that. Supervisor of chemistry would be in charge of toxicology, therapeutic drug monitoring, and molecular diagnostics. Supervisor of hematology would be in charge of coagulation, immunology, and urinalysis. Supervisor of microbiology is in charge of bacteriology, mycology, virology, parasitology. The supervisor of flow cytometry would be in charge of HLA and stem cell analysis. Manager support services, which is its own kind of bracket, is in charge of phlebotomy and central processing. So the way the lab is set up is you have a central processing unit in the center of the lab. Maybe you enter the lab and you walk straight into central processing. You scan in your samples, drop your samples off, and then they are distributed to the labs that the lab sections that they belong to based on the color of the tube and the test that's being drawn for. We also have coordinators of quality and compliance and coordinators of education. So education coordinator that oversees the lab, helps with training, things like that. The Clinical Laboratory Improvement Act, or CLIA, of '88 is a federal law regulating all sites performing lab testing in the U.S. must follow the same standard regardless of their location, type, or size. This sets requirements for the laboratory director, technical consultants, supervising, and testing personnel. This just means that all labs across the United States, no matter their size or where they are, in the hospital, independent, okay, they all run tests the same way. They all run diagnostics and maintain their machines the same way. Everything is done based on the regulations that CLIA of '88 put in place. That way, we can maintain stability and consistency in the testing results that we put out, send to patients, so on and so forth, right? Because the labs that Idaho hospitals and clinics send their blood to might be different than the labs that Washington or Oregon hospitals send their blood to, but sometimes patients can transfer hospitals and doctors, so we need to make sure that we have a consistency in care and that hospitals and doctors in other places can also read the results and make sense of the things that we are putting out, right?